Hello there again. I'm still Tony Mecham, Oral and Maxillofacial Radiologist. Today I'm going to be talking about arthritides, and that is the plural form of the word arthritis. So if that's the one thing you learn in this lecture, hey, at least that's something. So we'll be talking about osteoarthritis versus rheumatoid arthritis and others, including Lyme disease, infectious arthritis, and a couple of other ones. All right, so starting off with the big one, osteoarthritis, also called degenerative joint disease. This has to do with degeneration and disordered repair of articular cartilage, resulting in structural failure of the synovial joints. It's not really considered an inflammatory thing. I have been involved in a study where they did find low-grade inflammatory markers in it. I do kind of think of it as a low-grade inflammatory process, but at least this is the textbook answer that osteoarthritis is non-inflammatory, and we'll contrast that in a second with rheumatoid arthritis, which is considered inflammatory. So you can just kind of remember that. Prevalence does increase, of course, with age, typically older than 50, but it can occur at any age. If it's a really young patient, we'll talk about juvenile arthritis coming up later. And so, yeah, think of this as more of a disease of seniority. So these are the typical signs we talk about. Flattening is maybe a hit or miss. Someone could have joint flattening, and I might just refer to that as physiological remodeling, not necessarily a sign of arthritis, but especially if you start to see some of these other signs, reduced joint space. And I'm going to focus a lot on the TMJ, right? I'm a dentist, I'm an oral radiologist, so that's mainly the joint I'm looking at. Although in cone beam CTs, you see the spine as well, and you'll see all the same signs of these. And so reduced joint space, when I'm talking about the temporomandibular joint, we know we have that fibrocartilage meniscus in between the two different parts of the joint. And so once that meniscus gets eroded or flattened, that's when you start to see reduced joint space. And so if you have greatly reduced joint space, you know that's a sign usually of arthritis. Erosion, so that's when you have a well-defined, usually radiolucent lesion on the surface of a joint. So whether that's the condyle or sometimes it's less frequent, but it can happen in the articular eminence, even the glenoid fossa. So look for those erosions. And subchondral cyst, a lot of people talk about those as an erosion that's then been covered up by bone. We know in typical inflammation, I said osteoarthritis is not typically considered inflammatory, but in inflammation, it can kind of come and go. And so you can have erosions, and then as the process goes into submission, that erosion can be calcified over the top. And so you get these small radiolucencies, but they should be adjacent to joint surfaces if they are a true subchondral cyst. Sometimes these are called Eli cysts. Another sign is sclerosis. A lot of medical providers refer to that as eburnation. Trying to show it in the graphic here. Of course, in a radiograph, that's going to just look radiopaque, really completely white. And you start to get more of that opacity around the joint surfaces. That's a sign of arthritis, typically osteoarthritis. As bone tends to form on the surface or on the side of the joint, we'll call that an osteophyte. The colloquial term for that is bone spur. And so look for all of these signs. I'll show you some examples coming up. All right, this one right here, we see just some mild flattening of the condylar head. This is the articular eminence. Looks like we're looking at the right joint here from the sagittal, so like you're looking from the side. And so this is the condylar outline right here. This is more of a coronal view. If you look in the TMJ views, a lot of times they're going to be oblique because you can slice it to follow the medial and the lateral poles. But this is the coronal view, and you see a little bit of flattening, a little bit of thickening of that border. We'll call that sclerosis. And so if it's just some mild flattening, we might term that physiological remodeling. If I do see, and this is kind of borderline, if I see sclerosis like this, I might start calling it early indication of osteoarthritis. And then down here and see it's more advanced. See this anterior beaking? The condyle usually should have a nice curved surface. The articular eminence as well should be continuously curved. So if you start to see beaking here on the anterior portion, that's usually the first place that you see osteophytes in the temporomandibular joint. And then this is a cadaver specimen that's been sectioned. You can see a lot of the sclerosis through here. You can see these kind of, it looks like fatty marrow spaces, but these look like Eli cysts associated with osteoarthritis. Flattening of the articular eminence, sclerosis through that component, the temporal component of the TMJ. Here's some better examples of Eli cysts. In fact, this is a fairly large one. Usually well-defined and corticated like this, so it can look like other pathology. But if it's adjacent to a joint surface, good chance it's going to be an Eli cyst or a subchondral, also called subcortical cyst. All those are synonyms. Here it is in the coronal view. So same thing, well-defined. It's round. It's right against that joint surface, and that's just a subchondral cyst. This one shows more serious flattening, maybe not to where I would call it severe, but moderate flattening. It's also lost that cortical outline. So you might describe this as erosion, especially as you look at it here in the coronal plane. You can tell it's kind of cut out. A scooped out appearance, although we use that term for something else. But that cut out appearance would be an erosion. These are fairly large. Usually they'll be smaller than this. Here's a case. What do we see over here? Hopefully you can start to recognize this now. Some flattening, some sclerosis in the condylar head, little osteophyte formation. But there's also little radiolucencies going through that cortical outline. So this looks like erosions on the surface. This one shows severe flattening of the condylar head. A little bit of flattening of the articular eminence, but what do you notice about the joint space? That's reduced. And so what that tells you is there's not a healthy disc in there. If there is a disc, it's either eroded or more likely it's going to be displaced. So hopefully you know about disc displacement. I talk about that in my TMJ lectures. But here's another osteophyte, very apparent anterior beaking of that condyle. And so that's a pretty large osteophyte. And what did we call these? Well-defined round radiolucencies. Right near the articular surfaces, those are subchondral cysts or subcortical cysts. You can also appreciate the loss of joint space here. This is not enough space for a healthy disc. And then I'm going to show you some examples from my practice going from less to more severe osteoarthritis. And in fact, this one I would not call osteoarthritis. Maybe there's a little bit, just some mild flattening. That could just be anatomical or just some physiological remodeling. And so look at the nice cortical outlines. Some people might argue there's a little anterior beaking here. I think that's a little aggressive diagnosing if you call that an osteophyte. This just looks like a normal temporomandibular joint. All right, and then this one, see how the medial pole just looks more radiolucent? We also see what looks like little surface erosions, and then this one becomes more apparent. And here I like when you see this, when it looks like a chicken, that's just osteoarthritis. Could be other forms of arthritis, but you see changes of osteoarthritis or changes of arthritis because you see that anterior osteophyte. What looks like the chicken's eye right here would be what? That's a subchondral cyst. Loss of joint space. See the loss of joint space there as well. Almost looks like bone-on-bone contact. So the more you get that loss of joint space, if you do get the bone-on-bone contact, eventually you could get ankylosis and the patient would be completely locked up. The left joint, it has better joint space, but still erosions. Eli cyst, or you might describe that as erosion through the medial pole of the condylar head. There's definitely a surface erosion, also sclerosis throughout the condylar head, and a little bit of osteophyte formation. So all these signs of osteoarthritis, just like you would expect. All right, what do you think about this one? Give you a minute to look at that. And so if I told you this was a 12-year-old patient, it should probably change the way you're thinking, because the mandibular condyle is a growth center for the mandible. And so this continues to grow until about puberty. So if this patient's only 12 years old, and you'll see even more so on younger patients, you're not going to see that well-established cortex like I showed you in the other normal case. In adults, that's what you're looking for, is a nice, well-established cortex. And so if you see this in a child, you're not going to diagnose it as arthritis right away. And we'll talk about juvenile, so hold off on that idea. But if I don't see obvious erosion or severe radiolucency throughout the condylar head, this is just normal. All right, as I said before, you'll see all the same signs in the spine. This is the anterior arch of C1. This is C2. You can always tell C2 because it looks like a thumbs up. The dens, the odontoid process of C2 is right here. And then C1 is really just kind of a ring. And so the anterior arch of C1 and C2, you should see a little joint space here. But we see sclerosis, we see loss of that joint space, we see some osteophyte formation. We even see some calcification within the disc here. So they've lost some disc height. We see these osteophytes, maybe even some little anterior longitudinal ligament calcification here. And so these are pretty moderate changes. This is just one view, so I'm not looking at the facet joints as well. If you are looking at a cone beam, obviously you have to look at everything, so you have to scroll in and out and evaluate all the joint surfaces. So in this next one, we see a little bit of the facet joint in the coronal view. We see these osteophytes, maybe a little ligament ossification. But why is this so dark here? So hypodense. If something is that hypodense in a cone beam CT or in a CT, it's got to be one of two things, either artifact, or if it's truly that dark, that's air. So you can see air spaces really well. And that's kind of a unique thing about the spine. They call these pneumocysts. This is related to intervertebral disc vacuum phenomenon is what they call it. It's an accumulation of nitrogen gas, but it is just associated with osteoarthritis. Just another example of the spine. This one you can tell in the other views. So look in the coronal view and you can see where the crosshairs are lined up. And I'm looking at the right facet joint between C2 and C3. And there should be a joint space there. It should be a normal joint, but that's fused. Sometimes that can be congenital, but in a lot of cases, especially if you see other signs of osteoarthritis, that's going to be a factor of osteoarthritis. All right, so that was the big one, osteoarthritis. Let's get into rheumatoid arthritis, which would be number 2 on my list of importance. This one is considered inflammatory. This is an autoimmune synovial membrane inflammation. And so what's the big difference here? If you compare this cartoon to the cartoon of the osteoarthritis, you're going to notice that there's a pannus. That's showing chronic inflammation within the joint space. So be aware of that. This is also showing bony ankylosis, which can happen in osteoarthritis or other forms of arthritis, but it's kind of known to happen in rheumatoid arthritis. So this one tends to affect females a lot more regularly. You see 3 times more common in females, usually between the age of 30 and 50. So compare that to osteoarthritis. This is a little bit earlier. And so that would be one factor to compare with osteoarthritis is the age. If someone's 35 years old and you start seeing these degenerative changes, and if it's a female, you might think rheumatoid arthritis rather than osteoarthritis. And this I mentioned, granulation tissue, pannus. It tends to be very erosive. And I'll show you here in the next image. Probably tough for a dentist to recognize this, even myself. I don't look at hand radiographs, but there's some osteopenia along the joint spaces. And then another typical feature of rheumatoid arthritis is the ulnar drift of the fingers, so drifting outward. Another example here of your temporomandibular joint, and really tough to see detail here, but what can you notice? Look at the patient's occlusion. So their chief concern might clue you into something. Over several months or years, their anterior bite has been opening. Usually that's a sign that something's affecting the condyle, the condylar heights. And we just said on the last slide that rheumatoid arthritis tends to be osteopenic. It tends to erode bone. It can really destroy the height of those condyles, as it does because of the lever effect, as the mandibular rami kind of have to ascend upward to meet the articular eminence. That opens the anterior bite. And so again, I'm rehashing that rheumatoid arthritis tends to be erosive. It doesn't tend to cause osteophyte formation, but do be aware that there can be secondary degenerative joint disease. So it can kind of accelerate the other signs of osteoarthritis. I typically think of this as more of an early onset and maybe more of an aggressive osteoarthritis that affects females usually earlier than osteoarthritis would. If it's severe enough, it's going to lead to pain, stiffness, swelling. Where does rheumatoid arthritis usually affect? On the last slide we showed you in the fingers. So usually it affects the peripheral joints. So in most cases, a patient will be aware of rheumatoid arthritis by the time it starts to affect the temporomandibular joints. And they can do the lab values, obviously Rh factor, the rheumatoid factor. Also high markers for inflammation in the blood. So ESR, CRP, and high CCP antibodies. Those will all lead to the diagnosis of rheumatoid arthritis. This is that same picture from the last slide. This is an old tomogram they used to use. Now we have CBCTs that'll show better detail of the joints. But this sharpened pencil appearance where it looks like it comes to a point rather than a nice rounded cortical outline, a nice rounded condylar head, that's kind of a classic sign of rheumatoid arthritis. It's not unique to rheumatoid arthritis. It could indicate any of these others. But as I said, rheumatoid is kind of the big second one. I think it was a more severe form of osteoarthritis. Osteoarthritis doesn't do this as often. Usually it's more just flattened from the top. And so that could be a unique thing about it. These are some images showing varying degrees of ankylosis. See how sclerotic this bone is? And we said rheumatoid tends to be more of an erosive disease, but it can kind of exacerbate osteoarthritis. But you also have erosions throughout both the glenoid fossa, through the condylar head, osteophyte formation, and in the sagittal plane here, what's this arrow indicating? You got this bone-on-bone contact. There's actual bony ankylosis, so that's going to be a patient that's completely locked up. If you just have something like this where it looks like 2 jigsaw pieces fitting together, that tends to be more just fibrous ankylosis. That'll still affect them. They'll probably be painful and have limited movement, but maybe not complete limitation as if they had true osseous ankylosis as we see here. All right, on to Lyme disease. This is an infectious disease caused by the bacteria Borrelia burgdorferi, And if you remember this one, this is the classic sign, right? You see this erythema migrans rash, the target, the bullseye target, that red rash that you get, that's classic for Lyme disease. But it'll also be associated with fever, chills, malaise. They'll feel very sick, right? All these different symptoms. And this is the early onset, within the first month, within days to weeks following the tick bite. After the first month, sometimes they refer to this as disseminated, and that'll lead to neuropathy. So it affects the nerves and secondary skin lesions, not in just the original source of the bite, which is where you get that first erythema migrans, but you get secondary rashes away from the initial source. It can also lead to heart problems. And then arthritis is really a late stage symptom that they might get. But I think of it as a form of inflammatory arthritis because it is a response to infection that can accumulate in different joints. It's known to accumulate in the knees. Also can lead to thinking and reasoning problems. So this is a serious disease, right? If you've known anyone that has it, it can get really serious. And so we're in Utah. We're not really worried about Lyme disease. Why? Because the type of ticks that carry this are really just in the upper Midwest, Northeast, the Mid-Atlantic states. So what are we at risk of here? Here we have Rocky Mountain spotted fever. That's caused by a different pathogen, Rickettsia rickettsii, and transmitted by different ticks. But also it's associated with high fever, headache, myalgia, rash, systemic involvement. But that one's not as well known to be associated with arthritis. And so recognize the Lyme arthritis. That's something that can come up on boards. And then just really quickly, other forms of arthritis. This juvenile idiopathic arthritis, maybe I should have had a whole slide explaining that, spend a little bit more time on it. But this is what used to be called juvenile rheumatoid arthritis. If you see arthritis in a child, under 16, good chance it's going to be this one. It looks like all the signs we showed you for osteoarthritis, but it's in a child. They stopped calling it juvenile rheumatoid arthritis because it's not necessarily associated with the rheumatoid factor. They found that, and so they renamed it just juvenile idiopathic arthritis. Infectious or suppurative arthritis. I mentioned that Lyme disease, I kind of consider a form of this. It is an infectious thing, but there are different forms of infectious arthritis. You can have a direct infection, an injury right over a joint, and that can lead to infection. Or it could be a bloodborne infection that just tends to settle inside a joint and cause arthritis. So look for signs of infection within and around joint. If you don't remember what that is, what does infection do to bone? What's a bone infection or osteomyelitis? There are a couple classic signs of that. Look for periosteal reaction or look for sequestra. In this case, we see some erosion through the right condylar head. This is an axial slice. So we have the right and left here. Maybe some subchondral cysts here. Tough to really tell, but it really looks like an erosion right there. And then the arrow is indicating this sign that really differentiates it from either rheumatoid or osteoarthritis. The fact that you see this well-defined outline, it parallels the bone, that's your periosteal reaction telling you there's an infection in there in the bone. And so that's our infectious arthritis. And then there are a host of seronegative spondyloarthropathies. These are a group of autoimmune diseases. I think of these as rheumatoid arthritis, but it affects more central joints. I think the most popular one of this, or most common one of these, is ankylosing spondylitis. And these are associated with the HLA-B27, so they can be diagnosed with a blood test. It is more common in men, and this is something called bamboo spine because it can lead to fusion and ankylosis of the joint. I'll show you a picture of that in a minute here. All right, these are the pictures of bamboo spine. And so what you get is these osteophytes form on the end plates of the spine. The spine should not look like this, right? There should be space in between each of the vertebral bodies. But this bridging osteophyte formation is what you see, and that really stiffens the spine. It's basically ankylosed, which is where it gets its name, ankylosing spondylitis. More common in men, so that is different than rheumatoid arthritis, and occurs maybe around the same age, actually probably a little bit younger than rheumatoid arthritis, so in 20s or 30s, where we said for rheumatoid arthritis it was 30s to 50. All right, but that is it for our arthritis lecture. I'll see you on the next one.